Rohit Kavishwar. I'm currently fellow with Professor Park at Daejeon Hospital, South Korea. So here are some of the interesting cases he operates. So it's a 61-year-old female. She has right lower limb radiculopathy. VA score is 8. There is no she has a motor weakness on the right side. L5 is grade 3/5. No bladder bowel involvement. This is the MRI scan. So this is the disc. I mean, it is extending from behind the whole body of L5. So what do you think should be the plan?
Yeah. What is the plan? So anybody? What do you think?
Looks like an extruded disc. So yes, surgery.
Actually, this patient has a severe downward migration from L45, very severely migrated on the right side. So what is your plan to remove all severely herniated disc right side?
Yeah, Professor Rajan.
Yeah, I think I will do interlaminar microdiscectomy or uniportal microdiscectomy from the right side. Since it's not there on the other side, so one side should be good enough.
Yes.
If I'm using uniportal.
Yes.
Or even if it is interlaminar microdiscectomy, the incision should be around 1 centimeter away from the midline. Just dissect out the fascia, reflect towards the midline, strip the muscle, and you are right there in the interlaminar space.
Yes.
Since it's migrating down, so probably even need not touch the lamina. This is going to be quite low down.
Yeah. So this patient is so severely migrated disc. So for a total removal, we have to consideration 4-5 and 5S on 2 level, or how can you remove it totally? So my conclusion is, my experience is, show me. Okay. So this patient is so for right side laminotomy. We are worried about iatrogenic pars injury or facet joint injury. So next. My conclusion is one level over. Okay. Same level. Actually, I made the left side interlaminar keyhole. Left side interlaminar keyholes and foramin and the contralateral sublaminar approach. Midline. When you access intraspinal area, your legal problem will guide you. I mean, attachment to ligament problem. So making contralateral keyhole, and then we can make a sublaminar laminotomy, and then we can take out the contralateral side, especially right side migrate disc with the minimal injury to the facet joint and minimal injury to the pars interarticularis. Only making contralateral side interlaminar keyholes. Because of the contralateral side keyhole, we can make some tanning. Important thing is decompression on here is the root. This is the root, affecting root. This is the axial root. Also, we have to make sure shoulder part of root. Because we made a contralateral side keyhole, we can make sure axillary area and also shoulder area. So I believe this is some advantage for a contralateral approach. This is for disc face. This is downward migrate from the 4-5 to the caudal migration. Here is the left side. So my meaning is if you have a right side approach, you made more severe laminotomy and some injury to the facet joint or pars. But if because I made the contralateral side keyhole, I can preserve the facet joint and the pars more effectively.
So the contralateral decompression from the contralateral side.
Yes, this is
always easier.
Yeah.
Agree with you.
Yeah. So I'm introducing the contralateral approach with the endoscopic surgery.
Correct.
And another show.
Basically, he's a fan of minimally invasive surgery. So the aim is to protect the facet joints.
Yeah, very nicely done.
So another interesting case where a patient had 59-year-old male. He had an active lifestyle. All the Koreans like to hike, and they have very active lifestyle. And he had right lower limb radiculopathy since 1 month, and VA score was 8. He also had ankle weakness and dorsiflexion weakness, and he had a history of previous surgery 1 year back. So L4-5 microdiscectomy was done from the right side. So this is the patient scan, no obvious instability, and now
Actually, this patient also severe migraine disc, but this patient has a previous laminotomy here. Previous laminotomy here on the right side. We can use the same method, but this patient has already have a laminotomy. So I made a different method. Okay.
So what are the options? Do you think this is the previous thing? So what do you think we should go do the microdiscectomy from the same route, or if it's
So
endoscopy?
is it recurrence of the disc, I guess? So that is the reason I think in sort of our philosophy, I would say, not only the migrated disc, we remove whatever loose fragments are inside the disc space. So if you do, I mean, only remove the migrated one, then you are likely to have, recurrences once in a while.
So we choose to do one level above approach. So our disc fragment is on the right side, where the defect of microdiscectomy is there. So this is like one level above approach, and because we are going through the virgin area, there is no chance of any injury. So this is professor's idea to go through. This is the current CT, but we did a keyhole there, and went in from this side.
So this patient has a previous surgery, so revision surgery is not easy compared to virgin surgery. So my choice is contralateral one level above interlaminar approach. So from caudal to cranial, so making holes, keyholes to the one level above, and the contralateral sublaminar approach. So here is left side, one level above interlaminar, and going to cranial. Caudal area. So ligament flavum, when you follow the ligament flavum, we can meet pedicle, and we can meet medial wall of facet joint. So I believe if you know the anatomy of ligament flavum very well, it's very easy to find our way during our operation. So we are here, contralateral SAP, tip of SAP, more caudally going to. Here is your adhesion because of previous surgery, and you can meet ruptured recurrent disc, site for recurrence. If you have contralateral sublaminar approach, this is a root, you can make sure shoulder part of root and the axial part of root. If you have revision surgery from distal level or proximal level, it is very difficult to make sure axial part and shoulder part both. But if you have a contralateral approach, it has some advantage to make sure axial and the shoulder part together with effective preservation of facet joint. And we can escape from the previous adhesion, which is made by previous surgery.
So the post-op patient was fine, and the beauty of biportal or any endoscopic surgery is like we can really see contralateral side more beautifully. So this is the old laminotomy, and this is the keyhole which we made.
Keyhole here, and remove this direction like this.
So we didn't touch the facet joint at all. So it's truly minimally invasive in its own sense.
Rohit, in the MRI, post-operative MRI, was there a disc? I mean,
This one?
yeah.
Basically, they usually just do the sequestrectomy, not the aggressive going to the disc space. Only, and what I observe on my training in India, we used to go into the disc space and do some aggressive discectomy. But what I observed in Korea is more of it is sequestrectomy, and then they come off quick. I mean,
And the chances of disc recurrence when you do a sequestrectomy, see, there are two school of thoughts that do aggressive discectomy versus just do a sequestrectomy. But what about the chances of risks? Because in Korea, you said there are too many patients who do hiking.
yes,
So the chances might be more.
Oh, I don't have any idea. That's why I'm a bit confused myself.
Professor
So,
Park might be.
Professor, you can take that question, I think. What are the chances of recurrence when you just do the sequestrectomy and don't do aggressive discectomy?
Yes. Actually, for my clinical experience and comparing many reported report tell us their recurrence rate is nearly similar. Most of our reporters tell us the recurrence rate for between sequestrectomy and intradiscal removal are usually similar recurrence rate. In my clinical experience, also I like to remove the cicatrictic disc and only superficial portion, It means pre-fragment, which is located intradiscal area, gush out, wash out. Not invasively removable annulotomy, I don't like it. Massive annulotomy makes some recurrence or segmental instability, I believe. Only scaphoidectomy and the intradiscal pre-fragment removal, that is the best way, I believe.
Thank you.
Thank you very much, sir.
And also, I think the RF helps in the annulotomy, annuloplasty at the end. That's again a power of endoscopic surgery. The back pain, they ablate the sinovertebral now, and the back pain is really less for the patient.
If it recurs again, what will be your approach?
The same disc, third recurrence, what will you choose? For the same patient, third surgery? Second recurrence?
Usually one recurrence means the first recurrence, I try to the PLD again. But if I have PLD means the transforaminal unifocal disc removal. And then my patient have a recurrence of disc again, I try to PLD again, transforaminal unipolar disc removal again. And by bipolar surgery, we just like open microdiscectomy, laminectomy, and flybectomy and discectomy. If my patient has recurrence, I have a revision surgery with a interlaminar approach or transforaminal PLD. But further recurrence, it is depend on the patient's situation. But the disc patient has some segmental instability such as lateral recesses or other things, I recommend fusion surgery. But the disc is relatively healthy, only moderate changes are there, I recommend again revision surgery. That is my opinion.
We have one more case to show. It's again an interesting case of a 69-year-old female. She has neurogenic claudication. Motor power is full. BMD is minus 1.3. She has active lifestyle. And this is a grade 1 spondy on X-ray, but relatively stable. The movement is less than 4 mm on dynamic films. And this is her MRI. This is a hypertrophy of the facet joint, severe facetal arthropathy. Now, what will you choose? But patient, I mean, what I have seen, like patient really don't consent sometimes to fusion in these countries where they allow to hike or move, but they they are scared of fusion. So what is your choice?
Everybody 100% agree with interbody fusions. But this patient has flexion and extension view. There's no segmental instability. Only translations are there. And the patient has a severe spinal canal stenosis. Also right side severe lateral recess stenosis. CT scan. You can see here is the main focus of pain. So my choice is left side interim, left side ULBD, left side approach, left side making approach, and ULBD, both sides decompression, especially for the bony compression over here. And then I try to the semi-rigid fixation. My focus is here. For the right side asymmetric stenosis, right side compression is more severe, but my approach is left side. Because I have a left side contralateral approach here, I can preserve the facet joint more effectively to reduce the operative instability.
The interesting thing is the patient has flexible rods. I have seen only at his hospital. It's not a fusion. The screws are in, but the rod is flexible. It's not a regular rigid rod.
So my talk is if you have a contralateral approach, your surgery sometimes you don't need for removal of this facet joint, and we can preserve your facet joint more effectively, especially for the upper lumbar spine. Yeah, with the contralateral approach, we can drill out this bone, because if you have a contralateral approach, you can find the normal flap more easily, and dissection of epidural space from the ligament flavum bones is more easy. So especially for the right side region, I have nearly always, over the 90%, I have a contralateral approach, because we need we can preserve a facet joint more effectively, and we can dissect dura from the ligament flavum or other lesions. So when you have a central located disc, contralateral approach is very difficult, but laterally located disc or lateral recessed stenosis or foraminal lesions, contralateral approach is very effective with effective preservation of facet joint. This is traversing node, and here is the lateral recess.
I'll quickly go through one case. There was a lot of interest in marking of portals in the cadaveric workshop. So usually the portals are medial for going interlaminar. But what about paraspinal? So paraspinal, he has a very interesting technique when you don't need anything. I mean, you just don't need to decompress the foramen. So we will just go through the video. I'm not getting it. Okay, sorry.
Yeah, so we can have a lecture, the end block resection of butterfly technique,
Just
right?
now? Okay.
Yeah, we can have the professor's lecture. And Dr. Manoj can be ready with his case, if at all, or otherwise Dr. Paresh can have his case ready. Pankaj sir, where are your cases?